Assalamu alaikum, everybody. I'm pleased to be participating in this interesting master class. And today I'm going to talk about antifibrotic in systemic sclerosis ILD. So this is my disclosures. Now I'll be talking about the rationale of using antifibrotic in systemic sclerosis ILD. And I'll talk about the landmark studies. So Dr. Rajai presented the previous, like a hallmark of the study. So I'll be talking in details with regard to the studies itself. I'll be talking about the indication of antifibrotics, and maybe that's an interesting subject to our colleague rheumatologists, like when do we start antifibrotics? Now, let's talk first about the evolution of the management of systemic sclerosis ILD. Now, in 2007, that was the start with the cyclophosphamide, proven evidence. It's better than a placebo in systemic sclerosis ILD. And then 2016, another big jump happened, and actually it changed the practice, at least for us as a pulmonologist, that showed MMF is equivalent to cyclophosphamide with less side effects. And then in 2018, tocilizumab comes into the surface, and that's again a big hit in the world of interstitial lung diseases related to systemic sclerosis. Furthermore, it comes my talk, like antifibrotics in systemic sclerosis ILD, it actually have a big impact on our practice. And now one thing more, in 2023, EVER-ILD is another landmark study that I would encourage myself and all of you to read more in depth, and it was presented in with my colleague in the last lecture. Rituximab, adding it to MMF could be better than MMF alone. And that was a study published last year in June 2023. Now, maybe you heard about the pathogenesis of systemic sclerosis ILD with my previous colleagues, and here I'm going to just highlight the role of antifibrotics in systemic sclerosis ILD. So here, back into the lab. Now, the interstitial lung diseases related ILD has three main pathways. So you agree with me that it is secondary to fibrogenesis, vascular dysfunction, inflammation, and autoimmunity. And that's my part for the fibrogenesis pathway, and it ends by the tissue remodeling with fibrosis. And here it comes the pathways of fibrosis in systemic sclerosis ILD. It mainly starts by the alveolar damage, secondary to maybe aspiration, maybe infection, maybe autoimmunity, alongside with endothelial dysfunction. So they goes together into activation of circulating fibroblasts with a circulating macrophage with regard to autoimmunity. And when we talk about macrophage, we need to be particular in our ILD world, talking about the M2 macrophages that would gonna have a TGF-beta, transforming growth factor beta signaling pathway, and it will end up by fibrocyte activation and myofibroblast differentiation. That's the factory of collagen deposition. So now the expectation. Now, whenever we start antifibrotics, the patient is not doing that well with regard to the ILD itself. So we need to understand what do we expect from starting antifibrotics, and we should have the bar lowered. So we'll have agreement with the patient, and I always sit with the patient and counsel them that, well, we start you an antifibrotic. We don't think you are getting any better, but our goal, not to make it will come even worse. So people, like patients, would be like a little frustrated. Then why are you giving me antifibrotics? Why are you giving me Ofev or nintedanib? Then, well, once fibrosis commenced, it is kind of autonomy now. So collagen will continue to be deposited. So then we need to slow the rate. I think, okay, my voice is loud, so I don't like to be any louder. All right. So then the target here is to slow the rate of decline of lung function. If the patient understands this, we will be friends forever with nintedanib or with any other antifibrotic treatment. But that's the expectation, and for which we need to have our primary outcome to be focused on currently. Now, we don't know what will happen in the near future, inshallah. Now, with regard to antifibrotic pathways, you can see here it's much complicated, right? So it has many signaling pathways. It has a tyrosine kinase pathway. It has a TGF-beta pathway. It has endothelial pathway. It has a lysophosphatidylate acid autotoxin pathway, and even cannabinoid pathway, and that's interesting. So many pathways, and I'm going to discuss most of the pathways. But first, let's talk about nintedanib. Nintedanib is a tyrosine kinase inhibitor, so it is an immunomodulator. And that I learned it more with rheumatologists, but we always call it as pulmonologists, antifibrotic. We just know it like that, but it's actually an immune modulator. So it exerts the main effect through the platelet-derived growth factor, vascular endothelial growth factor, and platelet-derived growth factor. Now, here is the census trial everybody is talking about. It is one of the landmark studies that has a great paradigmal shift of the management of systemic sclerosis, ILD. Look at this number, please, and try to memorize it. This is a huge 576 systemic sclerosis ILD. That's a huge, and you will gonna agree with me over the next slides with this recruitment. So around 300 on nintedanib, around 300 on a placebo, and mycophenolate was allowed. And why it was allowed? Because now ethically, it's not right to keep the patient absolutely off any treatment. So any medication that would go FDA approved and recommended in the guideline, and a patient is already on for almost 3 months, you cannot stop it, okay? Ethically. So look here, the primary outcome is viral capacity. So Dr. Rahma talked in detail with this regard and why we chose it. But now, how about the viral capacity? It's the rate of decline here, all right? And that's different from cyclophosphamide, different from tocilizumab, different from any other immunosuppressant therapy. So they are looking at the decline. Now, why we included the Radnan skin score? It's just because people thought, not we, they. So why they included Radnan skin score? It's just because it's antifibrotic, it has an immunomodulator effect, so people thought that it might work in the skin. And let's see that. That's a nice paragraph that showed, in general, patients on nintedanib are doing better than placebo. Look, with regard to the rate of decline. Okay, so the difference is significant. Moving through the second slide, you can see the early separation between the two lines, nintedanib with a placebo, start at week 12, where the medication first hit at week 12, and it continue to separate. Look here, again, this is the baseline, and here is the reduction, but the reduction is better. All right, and that's clinically significant, just because we're dealing with a fibrosis right now. Now, this is a very nice graph that was mentioned in the article, and you can see here the best result is achieved when you combine immunosuppressant with antifibrotic. So MMF with nintedanib has the best effect on the viral capacity. The worst behavior among fibrosing ILD is when you leave the patient without anything. Okay, and look here, we are talking about mLs, but mLs we're gonna pull another mLs. So here you can see that yearly reduction of vital capacity if you leave the patient without any treatment is 120 ml per year. And that's significant, all right? Whereas if you give either nintedanib or MMF, patient would at least do the same. And that's important to keep in mind when you want to counsel the patient. That's actually was important for us as a pulmonologist, especially like patients not tolerating MMF, they don't want to be on MMF, or they want to be on lower dose of MMF. And all the speakers in the previous lectures were commenting on the difficulties of reaching what's in the SLS2 target, which is a 3 gram per day. So something need to be kept in mind. Now, see this paragraph for us as a pulmonologist, remind us of the IPF graph, okay, that the reduction is almost like the behavior is almost the same, but just keep in mind that IPF are the worst among all fibrosis. So here the reduction is even 200 ml, and here is just like 120, and that's due to the nature of connective tissue disease, ILD. Now, look at this paragraph. That's again another interesting paragraph. Look here, if the patient is on nintedanib with MMF combined, they do better than MMF alone, all right? And if the patient is on nintedanib alone, they might do better than MMF alone. Maybe this is overestimated, okay? This is an analysis, retrograde analysis, and maybe this is an overestimation. But to me, to have an nintedanib almost equivalent to immunosuppressant, this is something good that I need maybe to discuss it with the patient. And the worst, of course, if you keep the patient without any antifibrotic therapy. And look at this again, paragraph is just like, just like talk about the similar concept. Now, let's talk about probability. The probability of antifibrotic to stabilize the disease is equivalent to the MMF. MMF with no MMF are almost like the same. Now, let's see about the improvement. If the patient is taking mycophenolate, then whether you give nintedanib or you don't give nintedanib, they would do the same. And then how an improvement then happen in a patient who's taking nintedanib? How is that? And that's something like we need to think a little about. What is my theory is in the improvement, maybe you're dealing with an early disease. We don't have much of details with this, but my theory is that with maybe those group of patients, they are an early disease journey. So even nintedanib can or have a potentiality to improve a lung function, but the majority is about stabilization of lung function. Now, and here it comes like MMF with nintedanib, maybe they have a synergistic effect, and maybe all of you agree with me, you're all like nodding along, and that's a good sign. Now, another study is an INBUILD trial. INBUILD trial is another landmark study. Actually, they run both studies, Census and INBUILD trial at the same time, and that's why the systemic sclerosis patients were a little less, okay? When you compare it, they are just like 23 patients and 16 patients in this study, okay? But this is like a diverse study that involves all fibrotic interstitial lung disease other than IPF. And here is the graph. No matter what is the underlying cause of your fibrosis, nintedanib would exert an effect. And another important slide is when you talk about a general population, the effect is significant. Now, when you talk about fibrotic pattern, which is a UIP pattern, look at the difference, huge, when we talk about patterns, okay? And people will, like as a pulmonologist, will argue back and forth. Is it a UIP or a fibrotic NSIP? Is it a cellular NSIP or fibrotic NSIP? And how is that would make any difference? But UIP is an extreme destruction of the architecture. And I mean, the pathogenesis is a little different than fibrotic NSIP, although overall, the prognosis is not good. But again, it's some of the experts would agree with me that UIP are the worst, okay, with regard to the fibrosis behavior. Now, when we look at this paragraph, look here, it's exactly the same, all right? So in the IPF patients, the reduction is 200. In UIP patients, the reduction is 200. So maybe when we go back to the census trial, maybe if they did an analysis based on the HRCT at the baseline, maybe we'll have a similar effect. We don't know. And that's something important, like if we want to have any studies in the future to further classify the pattern. Is it UIP? Is it fibrotic NSIP? Is it or cellular NSIP? And that, I believe, is important, not only for research point of view, but also for counseling point of view and prognosis point of view. Now, another way is about like talking about other tyrosine kinase inhibitor. Maybe rheumatologists would know better. So tyrosine kinase inhibitor, like one of them is nintedanib, but we have lots of other tyrosine kinase inhibitor. One of them is imatinib, nilotinib, and a lot of medication that's been used even in oncology world as well as in rheumatology world. And actually, to cut it short, imatinib is like giving us a conflicting evidence. Like some studies which show a good effect, other studies which shows like a placebo effect, and other studies with even signal serious side effects. So to cut it short, like imatinib, maybe further study is needed. Maybe you don't have to think much about. Now, let's talk about other pathway here. So with regard to the TGF-beta inhibition, and that was most of the research or lab evidence with regard to the fibrosis being conducted and animal models being mediated for the TGF pathway. It's a bit low in the fibrotic cascade. It's not up. It's a bit low in the fibrotic cascade. So we're blocking it. Hopefully we're gonna aid into resting the fibroblast and not having it much activated into myofibroblast. That's the theory about starting pirfenidone. Now, in Lotus trial, it was like a phase two, just like looking at the safety. They don't care anymore about anything else but the safety. Look at the number here. Right, so you would agree with me, the number is very low. Okay, it's just a safety trial. And it just like for a short duration. Again, it's 16 weeks. Again, it's okay, it's just for 16 weeks. And again, MMF was there. All of the patients were on MMF. But the whole idea is about the titration of pirfenidone. Pirfenidone is a little frustrating because you would start with 801 3 times a day, and then you will increase it every 2 weeks until you reach 2400 almost. All right, so it's a bit frustrating, and most of the side effect of pirfenidone is like nausea, epigastric discomfort, and that's quite common in systemic sclerosis. So the whole idea is about the titration up to the target with regard to the 2 weeks versus 4 weeks. Will the patient tolerate it or not? So if you want to start pirfenidone, at least you started on a 4-week titration in systemic sclerosis. So it will give a time to the tummy to get used to the medication. And it shows like a safety profile, a good safety profile. And we know that pirfenidone and nintedanib are both safe to be used in fibrotic ILD. Now, these are the paragraphs over 6 weeks, 16 weeks. 16 weeks is like very short duration. You cannot even draw any graph out of 16 weeks. But again, it's mostly talking about the safety. It's very safe, but it hinted toward the idea of like having an effect on the lung function decline, like it have a positive effect. Now, it comes the RELIEF trial. The RELIEF trial, they tried again to duplicate the studies that have been done in systemic sclerosis, but unfortunately, see the number of patients, just 127 patients, all right? It is considered a small number. So 63 on pirfenidone, placebo, that's the maximum they reached, okay? And again, the same primary endpoint, and so it is terminated due to a low recruitment rate. And that's important when we want to like conduct any trial. You need to have a power on number of patients, and that's the reason mainly of their termination. Now, they extrapolated the data, and it showed that, again, it is hitting toward the same effect, that there is an early separation at week 12, okay, and that separation continue to be there. Again, the number of patients is low. Now, they still want to give a good evidence, just like the nintedanib, because the nintedanib, the effect of nintedanib was robust, all right, in comparison to pirfenidone. But, I mean, they don't have the power. The problem is the power of patient collections. And here it comes, the SLS3. It is a much of disappointment, I would say. All right, and maybe the result, by the way, I don't know how they will interpret it, but the result, by the way, is not yet officially published. Okay, so that's just a preliminary abstract presentation in one of the symposium. But look here, that's interesting. Look here, at week 3, Afwan. So at week 6, at week 9, okay, at week 3 also, there is a good effect, okay, early separation of the graphs. But look at the end, it's like losing its effect. You agree with me? As if the pirfenidone is losing the effect. And by the way, MMF was allowed. So it's just like the nintedanib trial. So if you are on MMF, you will continue on MMF, or like azathioprine. If you are not on, you will continue not to be on any medication. But this is like, I don't know if they will gonna close the chapter on pirfenidone or it will be still there. The whole idea is that it's safe, and that's more important, but will it exert a significant impact? That's a question for them to answer. But the graph is not doing well. Again, the number of patients also. And we don't know what happened, whether a patient like maybe dropped out or something. So we don't know really what happened. I'm really looking forward for this study to be published officially. By the way, it's not working. So next slide, please. Not working. The remote is not working. The pointer is not working. Hello? Oh, all right. Yeah. It's not working. The pointer is not working. Sorry. He's working. All right. All right, very good. Now, let's talk about, I'm a little perfectionist, so how come it's not working? How come it stopped in my talk? So anyway, so now another important pathway is the phosphodiesterase pathway. I mean, and we're really fascinated as a pulmonologist to look at the result of the phosphodiesterase 4B pathway. So now here, looking at it physiologically, phosphodiesterase play an important role in the body homeostasis. So it involves almost all parts of the body, the brain, cardiovascular, respiratory, GI, so almost all of the vital organs. Now, looking at it in terms of molecular pathway, so phosphodiesterase play an important role through the activation of cyclic AMP and cyclic GMP. So that cyclic pathway has an important role in the activation of fibroblasts in a molecular way, and also has an important role in the inflammatory pathway. So now, because I'm focusing on this pathway only, so they believe that phosphodiesterase 4B would inhibit the fibroblast proliferation, differentiation, and so extracellular matrix formation. Now, because of that, and because of this aspect, okay, the first trial was conducted among IPF patients, and it was a phase 2 trial examining the safety, and they categorized the patients between, this is IPF patients, between Nintadine abuse versus non-Nintadine abuse, and it was for a short duration of time, just maybe 3 months or 4 months maximum, but it shows a great effect in order, or when we talk about stabilization. Again, 3-4 months is nothing. You cannot draw anything, but at least we know it's safe. We know that it could be effective. And now they run a parallel lines because of their previous experience with nintedanib. So parallel lines, IPF, connective tissue disease, lung fibrosis. And here it comes Fibroneer trial. And that's the design of the trial. They categorize the patient with regard to the nintedanib use, with nintedanib, without an nintedanib. And it is, of course, a double-blind randomized controlled trial. And they examined the effect over 52 weeks duration, and we are really awaiting the result. I guess they finished the randomization, and from the last group who got randomized, they need to count 52 weeks, and then the whole study will be finished. Not yet, though. Now, let's talk about this interesting pathway, which is the cannabinoid receptor pathway. You can see it's even very low down in the fibrotic cascade, and it has an effect on the myofibroblast, on the fibroblast, as well as on the TGF-beta. And when we talk about cannabinoid receptor, it presents, again, in everywhere in our body, in the central nervous system, as well as peripherally. So talking about the lung, both receptors, CB1 and CB2, we are talking about cannabinoid. So CB1 and CB2 present in the lung, in the airways, in the interstitium, and also it's been present. It is on the even peripheral inflammatory cells, including basophil, eosinophil, and neutrophil, okay? And the ratio between CB1 and CB2 receptor is just different between one organ to another. But CB1 is mainly in the brain. But it has a very good, like if you give an agonist, I'm not like promoting to cannabinoids, but if you give an agonist, cannabinoid agonist, we believe that it will have an important effect on the inflammatory and fibrotic cascade. What is scary is that cannabinoid CB1 receptor, which is present in the brain, it will give us the psychotic side effect. And that's, we don't know. We don't want, of course, right? Like other people will be, maybe disagree. But anyway, here it comes, linabazem. So linabazem is CB2 receptor agonist. So we need to be relaxed. It's a CB2 receptor. It has no effect on the brain. But look at the number again. It has 42 patients. They then divided between placebo and linabazem. And again, they are talking about safety first. So here it comes, safety. And it was safe. It shows a very good result for the skin. So people got excited with this result with regard to the skin. Maybe we got a solution. But then they run a RESOLVE trial, which is a phase 3 trial, and that was a disappointment. So it's not effective, neither on the skin nor on the lung. So just like delete that from, so cannabinoid receptor is not in our now target pathways. Now, another interesting pathway is up in the fibrotic cascade. You can see here the autotoxin pathway. And autotoxin pathway is an important mediator to lysophosphatidyllic acid pathway, okay? And lysophosphatidyllic acid pathway, which is LPA. So from now on, I'm gonna say it LPA to make my life easier. So we have many receptors, 1, 2, 3, 4. And they are all presented in the platelet, in the fibrocyte. So you can see the LPA receptor is up in the endothelial surface and down at the fibroblast surface. So blocking the autotoxin, which is the mediator for the LPA, it seems an interesting like an interesting theory. Especially we like always to block up in the cascade rather than down the cascade when it gets more complicated, right? So now here it comes, the autotoxin. So I talked about it already. Now here it comes, the NOVESA trial. And they included patients with diffuse systemic sclerosis. And they classify it between placebo versus ziritaxestat. And the primary outcome was mainly skin, and the secondary outcome was the lung with a viral capacity. And it shows an interesting, again, result, but however, it was deceived. Because people, again, got really excited when they get the results. So they run the ziritaxestat among IPF patients, and it was terminated because of safety issue. And now the image is gray in the systemic sclerosis. So we don't know whether they need to conduct a trial or just like to stop it because of the safety issue. Now, let's wrap it up. Nintedanib as a TKI is good. Others is like no. Pirfenidone, maybe, actually. And linabazem, of course not. Autotoxin, absolutely not. And we don't know if we get a selective autotoxin inhibitor, okay? And we are looking for the result of the phosphodiesterase 4B antagonist. They call it nerandomilast. So that's something interesting. Now, when to start? That's a question for all of you guys. So do you need to start antifibrotic early or late? And upfront or combination or sequential? That's a question for you all to be discussed. And in summary, systemic ILD involve a complex pathogenic pathway. Selective systemic sclerosis patient would benefit from antifibrotics, and upfront or sequential, and future direction through targeting other fibrotic pathway. Thank you very much.